Should you worry about your diagnosis? Does your diagnosis actually matter? Does that label help you in any way? Does it help you get better treatment? Or could it actually make you worse to know your diagnosis? In healthcare in general, patients seem to be extremely concerned sometimes about their diagnoses. And when I say that, I do mean plural, because I've had many patients who come in with a laundry list of diagnoses, and they are essentially consuming their entire identity. On the other hand, I've had patients who have not felt that they have been given an accurate diagnosis, that they have not been accurately told what is going on and why they are in pain. In which case, when I come along and I give them a sufficient explanation, then that helps put their mind at ease, because then they know what is going on. So let's dive into it. I'm Dr. Anthony Davis with Shapeshift Wellness, and this is the Health or Hoax podcast. I teach people with chronic pain and recurring injuries to take control of their health using evidence-based lifestyle modifications like movement, sleep, meditation, and nutrition in order to, again, reclaim the active life that they deserve to live. If you ever want to work with me one-on-one, you can book a free call anywhere in the nation or the world. Just jump on my website at shapeshiftwellness.com. The link is always in the description. Now let's dive into the meat of today's episode. Should you forget about your diagnosis? Does your diagnosis actually matter? Does giving it a label and knowing what it is actually help? And many other questions that we're going to answer in today's episode. For example, do we actually know the diagnosis? Can we even arrive at a correct diagnosis? Does the diagnosis itself actually tell you the full story? What if the diagnosis is wrong? And does it change treatment? And ultimately, we're going to end today's episode talking about if we are not going to give a lot of credence to our diagnosis and not focus on it, then what should we do instead? Is there a better way? First, let's briefly touch on nocebos. I've talked about this in other episodes, so I'll be brief. The power of language is profound. So when your doctor tells you that you have degenerative disc disease, that sounds pretty scary. But the truth is that degenerative disc disease is simply a normal process of aging. All it is dehydration of the spinal discs, and this occurs normally in every human being, eventually, to varying degrees. Now, severe DDD, which is also known as osteoarthritis in the spine, is obviously worse to have than, other grades of osteoarthritis, but mild to moderate cases really are nothing to worry about. So the power of language and how I phrase that as a healthcare provider, if I take an x-ray of somebody's spine and I tell them they have DDD, that they have degenerative disc disease, I'm now going to scare them, which is going to make them afraid of their own body. It's going to make them feel fragile. It's going to prevent them from wanting to explore full ranges of motion, explore strength and conditioning for their spine, which is going to actually lead to worse hydration of the discs and worsening of the actual condition in the first place, and higher levels of pain and disability because they are avoiding movement, which movement is medicine. Movement is the thing that would keep their spine healthy and pain-free in the first place. So if I scare them by calling it degenerative disc disease, I'm making it worse for the patient. If, on the other hand, I said the same thing, I say, oh, your discs look normal, right? Well, okay, that's kind of a stretch of the truth. So I need to be honest as a healthcare provider, but I don't need to be scary. So if I say your discs look normal, I could just add normal for your age, meaning that although there is a little bit of degenerative disc disease, aka osteoarthritis, that is a normal finding and therefore nothing to worry about. So instead of telling them that it is called degenerative disc disease, I can instead simply leave it at, oh, good news, your spine looks normal for your age. Nothing to worry about, instead of saying, oh, degenerative disc disease. So a nocebo is when I say something scary as a healthcare provider, and that leads to you having worse outcomes. It increases your symptoms and increases your disability or other issues in your life. So I'm creating a disease by virtue of my scary language. So healthcare providers could avoid that by just framing things in a more positive light. I'll give you a couple other examples. Let's take a disc herniation. That sounds pretty scary, but if I just say, well, you have a little bit of a disc swelling, you have some disc swelling, then that's not as scary, right? So, there's a little bit of swelling of the disc, right? That's not nearly as scary as you have a disc herniation. And the truth is, that's all that is a little bit of swelling of the disc. It's not a huge deal. Now, I will pause right now and say, because I know some of you are probably wondering about non-musculoskeletal conditions or things that are a bit more serious than a little bit of DDD in the spine. In that case, some conditions need to be named, but they can still be framed in a way that leads to more positive, hopeful, or optimistic outcomes for the patient. So obviously something really, really serious like cancer needs to be named. But depending on the type, et cetera, and stage, it can be framed in a way and presented to the patient in a way that is less scary. Obviously, things that are benign should be presented as such. I even hesitate to tell patients that they have a lipoma because it sounds scary. It ends with oma, just like lots of cancers. And technically, it is a tumor. But it doesn't matter. A lipoma is very normal. So sometimes I feel these lipomas in people's low backs when I'm working on them, and they say, "What is that?" "Oh, in this area, and I've always I just have these knots." And I sometimes hesitate to tell them, "Oh, it's not a knot; it's actually a lipoma," for two reasons. One, lipoma. Oh, what is a lipoma? Well, it's just a collection of fat. Oh, you're calling me fat? No, I don't want to. No. So one is I don't want to call patients fat because that's not what I'm saying. I'm saying you have a nodule of fat that has collected in one location and it's not a big deal. And the other is the oma part, which is the tumor part, which that scares people. Oh my God, you're telling me I have a tumor? Holy crap, And then they freak out. So no. It's a normal finding. It's just a little collection of some fat. Don't worry about it. Or another common finding that I see all the time is scoliosis. And patients all the time, they come in to me and say, "Oh, I've got a scoliosis. Oh, my chiropractor told me I have a scoliosis. My physical therapist told me I have a scoliosis." First of all, these oftentimes are people that I look at their spine and I do an examination and I'm saying, honestly, if you hadn't told me that somebody told you that you have a scoliosis, I would not have noticed, which means that their curvature is very, very little. Now, if it's less than 10 degrees, we don't even call it, we're not supposed to call it a scoliosis. It's actually just a convexity. It's not a scoliosis until it's bigger than 10 degrees. So some healthcare providers are seeing a minor curvature in people's spines and saying, "Oh my God, you've got a scoliosis and that's causing all these muscle imbalances and that's causing all of your pain and you need to fix this and you need to do these corrective exercises. You need to fix your posture. You're basically a machine, but you're kind of broken. You're asymmetrical and it's going to cause all kinds of issues and wear and tear down the line and it's going to cause nerve issues and muscle issues and headaches and Shut the fuck up. Stop scaring your patients. First of all, I want to repeat myself, if it's less than 10 degrees, it's not even a scoliosis. And I've seen these patients and they come in and tell me it's a scoliosis. It's not. So words matter. I'm going to stop harping on it, but the words that we use to describe things impact how a patient responds to their current symptoms or condition. If we call it something scary, their outcomes are going to be worse. If we frame it in a positive way, even with the same condition, their outcomes are going to be better. And the last thing, just to wrap up my point about how some things need to be named, is that, well, again, things like cancer need to be named because they need very specific treatment, right? I'll touch on this later in the episode, but some things need to be named so that they can be treated appropriately. And that, of course, makes sense. However, and this may be very, very weird for some of you to hear, especially if you are not a healthcare provider, you're just somebody who's dealt with pain or injury or chronic illness or something like that. Some things, honestly, it does not matter what your diagnosis is. We'll examine this in a second, but I just want to plant a seed. Some things, it actually does not matter what your diagnosis is. It does not matter one bit. Okay, so I'd like to talk about how often diagnoses are wrong. So this is a big problem, is that if you go and you get a diagnosis and it's wrong, that can lead to terrible mismanagement of your symptoms and you and your health. So great, you got a diagnosis, but now because of that label comes a certain set of treatments. Maybe that involves scans, which involves radiation exposure. And then maybe that involves certain medications, and maybe those have side effects. And now we're making your health worse. And maybe that diagnosis was wrong to begin with. And so now you're getting a bunch of treatment that you don't need and is making your health worse for a condition that you do not have. This happens more often than you think. I had a patient. In fact, I'm just thinking of one patient. I'm going to tell you a story, but I have had many patients come to me with a laundry list of conditions and diagnoses, and half of them were wrong. Half of them objectively, measurably were wrong. And this was negatively impacting their mental health, which prevented them from exercising, eating right, getting good sleep, improving their social life. And that therefore very negatively affected their physical health, made their pain much, much worse, made their disability much, much worse, and all because they had multiple incorrect diagnoses that were all very scary, and these became their entire identity. They identified with their illness, and it made them worse because of incorrect diagnoses. Now, this is very difficult as a healthcare provider myself, because one, I'm challenging the idea of the diagnosis that they received from their previous healthcare provider. So I'm essentially saying, well, I think the other person was wrong. So that puts me in a weird, uncomfortable position, because that person may have run different tests or may have been provided different information that I'm not privy to. So it's hard to do that. And professionally, it's kind of you want to tiptoe across that line sometimes. And that is a very difficult situation for the patient, because I've had this backfire for me. I try to tell a patient, you do not have XYZ disease. Or I'm not even telling them they do or they don't have it. I've had this case with Lyme's disease, which is admittedly difficult to test for. But I've had patients where, I tell them, I just ask them, so how do you know? Because they come to me and on their initial evaluation, they say, oh, I've got this, and I've got Lyme's disease, and I've got this, and I've got this. And I say, okay, great. Let's just review. How do you know that you have Lyme's disease? I'm not saying you do or you don't have it. How do we know that you have it? And sometimes they have done 0 tests for it. There are tests for Lyme's disease. They're not great. I'll admit that. They're not great, but we do have them. So we should at least do them if we think you have Lyme's disease and see what they say. And I've had patients who don't do the tests, or they do some alternative medicine test. For example, some kind of, applied kinesiology tests, basically muscle testing, which I cannot emphasize enough. There is literature on this. There is good scientific literature examining the reliability of muscle testing and applied kinesiology. And overwhelmingly, every single time that we test muscle testing in a randomized controlled trial, and we test the ability of these practitioners to correctly identify strong and weak muscles compared to a dynamometer, and the ability of them to correctly identify things like allergens or other sensitivities based on muscle testing, overwhelmingly every single time these tests are terrible. They fail miserably. They don't perform any better than a random coin flip. They do not work at all. I can do an entire episode on this, and actually, we already did one. It was on applied kinesiology's ability to test allergies, and that was a really interesting set of studies that I reviewed in that episode. So you might want to go back and listen to that one. But my point is, okay, you've done these tests. You've gotten a diagnosis that is kind of a scary sounding diagnosis, Lyme's disease. Oh my God, it's an autoimmune condition that basically disintegrates your nerves. Holy shit, that sounds pretty fucking scary. Well, I'm your doctor. I want to make sure that you actually have it before we freak out about it, before we panic about it, before we start taking a million supplements and basically trying to treat a disease that may or may not exist. I want to make sure you actually have it. So the point is that we want to be certain of the diagnoses if we're going to give anything a label at all. Because if we give you a label and we give you multiple labels and they're wrong, they're definitely negatively impacting your health, your physical health, and your mental health. And we do not want that. And even if the diagnoses are correct, we still sometimes arguably want to downplay the diagnosis and focus on you as a human being, a real human being with thoughts and beliefs and attitudes and culture and likes and dislikes and goals and family and friends and work and all of these things that you want to do and dreams, right? We want to focus on you as a human being, not you as a diagnosis anyway. The next thing that I want to talk about is, frankly, and you might not realize this, our tests aren't even that good sometimes. So if you come into me, now I specialize in sports medicine, so I'm orthopedic, neurological health, that type of thing. So musculoskeletal. Basically, you get an injury, you have shoulder pain, you've got knee pain, you've got low back pain, you got chronic neck pain, headaches, whatever. That's me. You come to me for that, right? If you have chronic pain, I'm your guy. Now, if you come to me and I do all of these tests, I make you move and press here, lift here, bend there, twist there. Does this hurt? Does this hurt? Does this hurt? Does this hurt? Now, you might think that whatever I tell you after this examination is, 100% the truth. This is the diagnosis. If I tell you it's bicipital tendonitis, God damn it, it's bicipital tendonitis, and it's not a bursitis, and it's not a labral tear, and it's not a rotator cuff tear, and it's not just random muscular shoulder pain, right? It's exactly what I told you. And the fact is, unfortunately, our tests are not as reliable as even as most clinicians seem to think. So every orthopedic test that has any reliability whatsoever has been studied to evaluate for its specificity and sensitivity. So essentially, the ability to correctly weed in or rule out a particular condition as a pain generator. Now, the problem with this is that many of the orthopedic tests that we do, when we push here and we say, hey, does that hurt? Does that hurt? Does that hurt? They have, let's say they range between 60% and 97% specific or sensitive. So let's just replace those words specific and sensitive with the word reliable, because that's good enough for this type of conversation, and say, so basically we have between 60%, reliability, which is kind of a coin flip, right? And 97% reliability, which is pretty good. That's actually pretty good. That's fantastic, right? Now, so if I use those tests that don't have very good reliability, and I tell you, you have sacroiliac joint dysfunction or pain, right? Or sacroiliitis, or, oh no, you have a disc herniation, but I did not take an MRI. Well, I'm guessing. It's an educated guess. It's probably a decent guess, but it's still a guess. So I could be wrong. And then here's the other thing, is that even if I could identify the correct structure that's involved, that's still not showing you the full picture of why you're in pain. Because even if you do have a disc herniation, and even if it is pressing on a nerve, and even that, if that is causing your shooting pain down your leg, that still does not tell you the full picture of your pain, because pain is not an input. Pain is not a one-to-one correlation of stuff on an MRI equals this much pain. If your disc bulges 3 millimeters, then you are going to have a 3 out of 10 pain for 2 months. But if it bulges 5 millimeters, then you're going to have 7 out of 10 pain shooting down the leg for 6 months. It's just not like that. You're a human being, right? And organic life is messy, and you're not a machine. And it's not even just about the structural impact, right? It's not just about the disc herniation, the swelling on the spine. It's also about, are you even sleeping? Are you capable of recovering? Are you chronically, systemically inflamed? Are your nerves chemically more sensitive? Do you have central sensitization or peripheral sensitization where your nerves are physically just more sensitive to normal stimulus? Do you eat healthy food? Are you stressed out? How is your mental health? Are you depressed? Are you anxious? Do you have a good job? Do you have enough money to pay the bills? Do you have a social life? Do you have a family? Do you have friends? All of those things impact your pain levels and disability and the duration at which these symptoms will last and recover. It impacts your physical recovery and your mental health as well, which they then in turn influence each other. And besides, when we actually study people with zero pain. We take MRIs of people who have zero pain whatsoever. And it doesn't matter where you point the MRI. We could point it at the spine or the shoulder or the hip or the knee or whatever. You are going to see that people with zero pain, it is very common for them to have stuff on their MRI. In other words, it's very common for people with no pain to have disc herniations, disc protrusions, osteoarthritis, scoliosis, hip labral tears, shoulder labral tears, rotator cuff tears, meniscus tears in the knees. All of these things are very common for people with zero pain. That doesn't mean it doesn't matter, but it means that it's not the full picture. Hey, real quick. We've been talking about a lot of chronic pain issues, and things can get a little complex. Trying to heal on your own if you have chronic pain can be very difficult. It's a difficult road to walk alone. If you have been dealing with chronic pain or recurring injuries and you've tried other options and you have failed, or you've had minor success and then it just keeps coming back, I work with people virtually or in person. If you're in Colorado, you can book a free call with me, chat with me, understand what's going on with you, and I may be able to help you find a permanent solution to your chronic pain that encompasses your entire life and really accounts for you holistically as a human being, not a machine. So book a free call with me today, if that sounds like you. Now, the biggest thing is when it comes to should you forget about your diagnosis, should you worry about your diagnosis, the biggest thing to consider is, does it change the treatment? If it doesn't change the treatment, then it doesn't matter. Let me repeat that. If knowing the name or giving it a name, giving you a diagnosis and naming it, if that does not change what we are going to do for treatment, then it doesn't matter. So let's explore that. We have many, many, many potential pain-generating structures in the lower back. We have muscles, tendons, ligaments, joints, bones. We have all discs. We have nerves. We have all these things that could be sensitive in contributing to your pain. If it's this muscle versus that muscle, if it's the quadratus lumborum versus the erector spinae, am I going to treat that differently? Honestly, with most patients, no, I'm not. It doesn't matter, because the treatment for quadratus lumborum is, first of all, the muscles are really goddamn close to the erector spinae. In fact, they overlap. So if I treat one of them, I'm treating both of them. Now, you could use anatomy and say, oh, we need to bend this way or twist that way, blah, blah, blah. Fine. But that ultimately, When we study this kind of stuff and we try to do specific corrective exercise and we compare that to generalized exercise, we basically see that both groups end up getting the same results. So if it's not going to change the results, I don't have to change the treatment, which means I'm free to do rehab that's fun. I'm free to do rehab that you're actually going to enjoy. Oh, you like, person A, Susie likes yoga, but Billy likes weightlifting. Cool. Susie can do, even if both of them have the exact same pain with the exact same diagnosis, if Susie likes yoga and Billy likes weightlifting, guess what they're doing for rehab? Susie's doing some kind of yoga and Billy's doing some kind of weightlifting. Now, I might tweak their yoga and weightlifting to be more personalized for their condition, sure, but I don't have to give them a bunch of boring corrective exercises. So that's pretty good and reassuring. We can do fun stuff. Now, again, there are some conditions that I will treat in a specific way. If I think it's legitimately coming from a disc, yes, I'm going to teach you certain things that I believe that the research supports will improve your outcomes compared to doing, other treatments. So yes, some conditions I would like to treat very specifically, but most low back pain does not have that type of specific pain generator. So most of the time, it doesn't change the treatment. Therefore, we don't have to focus on the diagnosis itself. Okay, now let's wrap up. What do we do instead? Okay, so if you're gonna humor me and we're going to ignore the diagnosis, well then what the fuck are we supposed to do instead? Are we just supposed to throw up our hands and say, well, I guess we'll just wait and see how it goes? No, obviously not. There's a better solution. I look at it this way. If we are free from the diagnosis weighing us down, if we don't have to have that word drag us through the mud and fill our mind with fear and anxiety and movement apprehension and all of these negative things, if we are free of those shackles, then what are we free to do? We are free to focus on your personal goals, your unique life. So instead of focusing on treating the diagnosis, oh, you came to me and, oh, I think you have a little bit of a facet syndrome or sacroiliac joint dysfunction or a disc herniation. Instead of treating the disc herniation, now I get to focus on you. Right? I get to focus on you. Let's call you Lauren, for example. I get to focus on you, Lauren. I get to focus on what do you care about? Oh, you used to be a gymnast and you've had chronic pain for 10 years and now you can't do any form of gymnastics. You can barely even do yoga. Aerial silks, you used to love to do these, and now you're too weak and in pain, and it always flares you up, and you're sleeping more, and you're depressed, and it's impacting your social life, it's impacting your relationships, and it's negative. You can't even work as much as you wanted to, and now I'm trying to tell you that we're going to do some stupid, nerve flossing exercise that doesn't even make sense. Why are we doing this? How is this relevant to your goals? I can ignore all of that stuff and say, Lauren, you want to get back to gymnastics? Let's fucking do it. Now, every exercise that I give you is going to be one step closer to getting back on the mats, to doing whatever, a back handspring, to doing a cartwheel. What is it that you want to do? You want to be able to do a backflip again? That's fucking awesome. That's super ambitious, and it's going to take a long time, but I think we can get there one step at a time. So now my exercise, instead of doing boring rehab exercises, becomes let's learn how to breathe and brace so that we can create strength and stability as we move into, planks. And now that's weight bearing on the hands because we need to be able to walk on the hands because you want to walk on your hands again. Oh, well that's, so we go from a plank to a downward facing dog, and then we eventually lead into, modified cartwheels and et cetera, et cetera, et cetera. So now we're doing rehab that gets you one step closer to your personal movement goals. It's relevant. You're going to be more motivated. You're going to actually do your exercises, which means you're actually going to get better. You're going to get stronger and stronger and stronger. And you're going to just be involved and you're going to enjoy the entire process. And in the process, because it's fun and relevant, you're not going to be so obsessed with the diagnosis of the disc herniation. Now you're going to be more focused on, holy shit, I didn't even think I could. I thought I had to abandon this. I thought I would never do gymnastics again. I just was making peace with the fact that now I'm an old person. That's it. I'm 30 years old and I'm an old person and I can't do shit and it's all downhill from here. That's your mind space. And now, because we're focusing on your goals, we took you from this negative mindset to a mindset of like, I didn't even think that I could ever return to this kind of thing. And now you're fueled, you're pumped up, you're fucking jazzed, right? And just because of that, because your mood is improving, you're feeling better, not to mention all the movement that you're doing, right? So you can see how if we let go of the diagnosis and we don't allow the diagnosis to drag us down, keeping in mind, caveat, that yes, sometimes we need to know the diagnosis, and in those cases, we can know it so that we can have appropriate treatment. But then once we get on a treatment plan, let's not talk about it again. Let's just not even talk about it. Let's stop referring to it as a label. Don't identify with it. Just, okay, cool, there's a disc herniation, no big deal. Let's move on, right? So if we free ourselves from the diagnosis, we are free to do rehab that is personally fulfilling, that gets us closer to our personal goals, and that frees our mental health up so that we're not actually getting worse as a result of our diagnosis. I hope that this stuff makes sense. If you have any questions, I would love to hear from you in the comments. If you're listening to this on your podcasting platforms, please leave us a review. You have no idea how much it helps to get this information out to more people. As a reminder, you can always book a free call with me if you'd like some help and some guidance healing from chronic pain or recurring injuries. I'm here to help. Thank you so much for listening, and I'll see you on the next episode.